Good day, Mr. Israel. Could you please do a focused respiratory exam on this patient? Good day, sir. How are you?
And I, sir.
Good. My name is Israel Shingenge. I'm a fourth-year medical student. I've been asked by a doctor to perform a respiratory exam on you. It will involve me looking at you, touching you, and perhaps telling you to do some comments. Is it okay with you? All right. Sir, I'm going to ask you to remove your shirt and lie down. Again, remember every exam, it's always good to start from the inside of the bed because you see the patient very symmetrically. So you want to notice, I'm examining a young male, okay, who's of average build. Of average build is typically what you call normal weight. Because remember, if the patient appears to be cachexic, you are thinking, am I dealing with TB? Am I dealing with malignancy? Am I dealing with emphysema? Typically, those are your cachexic patients. As opposed to someone who appears to be obese, you are thinking, am I anticipating obstructive sleep apnea? Am I anticipating your blue bloaters in COPD? Okay, which we are not seeing. Then the next thing you want to see, how is the patient breathing? Okay, does he appear to be tachypnic? Remember, respiratory rate above 25 is tachypnea, which will suggest he's in respiratory distress. Other features apart from respiratory rate that you can pick up from afar, just from the inside of the bed, that the patient is dyspneic or is in respiratory distress. You can start up and go down. Look at the nose. Is the obvious nasal flaring, which we cannot see from here. Look at the mouth. COPD patients are known to purse their lips, breathing like that, which we cannot see from there. Then you move on to the neck. Are you seeing any obvious tracheal tag, like we see in COPD or other condition? We cannot appreciate. Then you look at your accessory muscle. Is a patient using accessory muscle, especially your sternocleidomastoid? We cannot see from afar. Look at the chest. Is there any obvious intercostal or subcostal recessions that you can see from afar? You can't. And finally, always remember that patients that are, especially COPD, they typically maintain an abnormal posture, what we call tripoding posture, which we are not seeing here. So it's useful to pick up from afar signs that will suggest respiratory distress. Okay. Then again, you want to look, what are you seeing? Are you seeing any obvious adjuncts? Okay. Patients with respiratory condition may need oxygen. So you are thinking, is it non-COPD in late stages? Are you seeing any obvious metered dose inhalers that you can see from afar, or any IV lines? What is the patient getting? Those are adjuncts. Another thing that is useful to note is, as I was speaking to the patient, I'm noticing the voice, okay? Am I hearing obvious stridor? Am I hearing obvious wheezing? Am I hearing a hoarse voice, which will suggest things like laryngitis or recurrent laryngeal nerve palsy? Again, those are all things that you can pick up just from afar. And finally, remember, this is the only time you see the chest symmetrically from afar. So it is useful to bend down and just see how the chest is moving. I can appreciate that there's symmetric chest rise. I can't see any obvious precordial deformities. That's what you do from the inside of the bed. So say I'm going to ask you to give me your hands. Okay, look at the hands of the patient. Okay, the first thing I'm going to ask you, sir, to do this. Okay, ideally, if you'd want, you put a paper to be very much easier to pick up what you call a fine tremor, which you typically get in if the patients are using especially beta 2 agonist. Okay, now I'm going to ask you to do this. Remember, here we are looking for negative myoclonus, or what you call asterexis. Okay, we typically see it if a patient has severe COPD, or it typically indicates that you have severe retention of CO2. Again, we are not seeing that flap that we normally get. Okay, then you come closer to the dorsum aspect of the hands. Okay, you want to start here. Are you seeing any obvious wasting of the small muscles, what we call guttering, which will suggest that you're dealing with things like Penco's tumors, which we do not see here? Look at the nail. Are you seeing any obvious signs of clubbing? Signs of clubbing will indicate loosening of the normal angle that you expect on the nail. Are you seeing any drumstick appearance, which you cannot see any? So there is no clubbing. And it's very useful to know the causes of clubbing in a respiratory station. Okay, remember, most conditions that cause a suppurative condition, lung abscess, lung empyema, bronchogenic carcinoma, if you are dealing with bronchiectasis, and very important also, idiopathic pulmonary fibrosis, those are conditions that can give you clubbing. Then finally, you start looking in between the fingers for any tar staining, okay, which we cannot see. Then you flip the hands over. Look at the hand. How do they feel? Typically, patients that are retaining CO2, they typically are warm, they are clammy, which we do not appreciate here. Are you seeing any obvious peripheral cyanosis, which we can't? Okay, it is useful to note that Pulse is not always routinely done in a resp, okay? But you do expect certain, for example, if the patient has severe asthma, they may develop tachycardia and also especially pulsus paradoxus, okay? And there are other features that can cause tachycardia in a resp condition. Okay, moving on to the face, okay? You want to inspect the face, okay? Does the face appear to be cushingoid, which will indicate that the patient has been using steroid for a long time, so chronic steroid usage, okay? Look at the face. Are you seeing any obvious plethora, okay? Plethora is seen especially if the patient retains CO2 or if you have superior vena cava obstruction, which is quite rare, okay? And finally, you want to inspect the face. Are you seeing any features in keeping with connective tissue disease? Remember, a lot of connective tissue diseases have manifestation on the lungs, okay? You have lupus vulgaris, you see in TB, you have lupus penial, you see in sarcoidosis, you can have a butterfly rash in keeping with your SLE, okay? Other microstonias and other features that may suggest connective tissue disease, which we do not see in this patient. And the next thing I'm going to ask, would you please look up, okay? You want to look for conjunctival pallor. Remember, pallor on a rest patient, you're thinking, is this patient having chronic illness, especially malignancy, tuberculosis? Again, those are giveaway, okay? Then the next thing that you must never miss when you're on the eyes is that look for any obvious signs of Horner syndrome. Horner syndrome, remember, it has a triad, that is miosis, which is a small pupil on that affected side. You have partial ptosis, and then the patient will complain that they have anhydrosis on that side, okay? Remember, Horner syndrome, if the patient has it, it will indicate that you are probably dealing with an apical tumor or malignancy compressing the sympathetic chain, okay, okay, which will explain the Horner syndrome, which we do not see here. So could you please open your mouth? Okay, again, you just want to see the overall hygiene. Are you seeing any broken tooth or rotten tooth that you're seeing that will predispose the patient to develop conditions such as pneumonia and especially lung abscesses? We do not see. And finally, say, could you please put your tongue on your palate? Let's see. Again, this way you see best just under the tongue to see for any obvious signs of central cyanosis. As the central cyanosis gets worse, the whole buccal mucosa become very cyanotic, which will be quite obvious, and we cannot pick it up from here. Okay, now we are moving on to examination of the neck. Remember, lymph nodes are best examined from the back, okay? Remember, you just warm your hands, make sure, alert the patient that I'm gonna touch you. Is it okay? Okay, and then you start with the submental, okay? You typically can get lymph nodes there, then you move down along the mandible for submandibular lymph nodes, then you feel for your anterior chain of your cervical lymph nodes. You can either slide like that or you can palpate them individually like that, and then you move on to your posterior chain, okay, which we do not feel anything. Your pre-auricular, this is your post-auricular, sorry, this is your pre-auricular, this is your post-auricular, and then finally you can feel for some occipital nodes. Then you can come down to your supraclavicular and infraclavicular, which we cannot appreciate any lymphadenopathy. Would you please lie down? It's very useful to know the causes of cervical lymphadenopathy, as we have listed them down on the video. The next thing that you want to test for is for tracheal deviation, okay? There are many techniques to this. One of the techniques, you use your two fingers, you stabilize the trachea, okay? And then you use your middle finger to slide through and see where you are deviating to. Are you deviating more to the left, to the right, to suggest that it's deviating that side? Again, we cannot appreciate any obvious tracheal deviation. Another thing that you can do at the neck, you can check for tracheal tag. If you're not so sure, you can check for it. Typically, you just want to put your hand at the trachea and please breathe in. Okay, and typically you see it move significantly inferiorly on inspiration. That will suggest tracheal tag. Remember, tracheal tag is typically signify that there is a gross overexpansion due to airway obstruction, which we do not appreciate here. Another useful thing that you can do is there's what we call a suprasternal to the cricoid distance, okay? So you take your three fingers like that, you go suprasternally to your cricoid, okay? If this distance is less than 3 fingers, okay, you are assuming if the distance is less than 3 fingers, you are almost sure that the patient is hyperinflated, as seen in COPD, which we do not see here. And finally, on the neck, it's very useful. So could you please look here? You could ideally assess for your JVP if the patient you are thinking has an element of core pulmonale. So the last thing that you do on the general exam of the rest patient, never forget, is to assess for edema. Remember, edema, you don't need to go all the way and trace where it goes, but you want to pick up if there is edema, okay? And typically, edema typically accumulates around the medial malleolus. This way it will most likely be if you have edema, especially if it's little. Okay, if it's obvious, then it will be all over, but it's here on your bony prominence. You just push it for a long time, then you check. There is no obvious edema. That marks the end of the general exam of a respiratory station. Okay, remember, on closer inspection of the chest, you want to always come quickly to the inside of the bed, just so you have a symmetric view at the chest, and you can even go to the eye level of the patient and notice how the patient is breathing. Are you seeing symmetric chest rise, or you think one side appears to be much more decreased movement as opposed to the other one? So always have your differential. If you have asymmetric chest rise, think about fibrosis, think about collapse of the lung, think about a pleural effusion, think about a consolidation, and all other things, as opposed to a chest that is moving but it's globally restricted in chest movement. Okay, so its chest movement is reduced bilateral to things like COPD, or if you have a diffuse interstitial lung disease, you can also get that picture. So it's very useful to comment on the chest movement. Remember, when you are checking for scars, to look and scan the whole chest. Okay, remember, by the way, you always do an anterior exam, then a posterior exam for a rest patient. Okay, look especially on the lateral aspect of the chest. Okay, you typically have patients that get ICD, so you want to see, is the patient having a chest drain? Here, the scar of evidence of previous chest drains that were given. And remember, scars, you can have one running in the midline, what you call a midline sternotomy. So you're thinking, were they doing procedures like cabbage, where they're doing a lung transplant, okay? And as opposed to thoracotomies, which can be anterolateral, they can be mid-axillary or posterolateral thoracotomies. They are thinking, where they're doing pneumonectomies, do they do a lobectomy? So that's a pattern of thinking that you have to use. So scars are very, very important. Okay, remember, when you're looking at the chest, you want to also comment if there are any precordial deformities. Okay, we see that in conditions like Marfan, and remember, Marfan has respiratory manifestation. So you want to see, is there an obvious pectus excavatum or carinatum that you are picking up? Okay, chronic asthma can cause precordial deformities, and you can also have what you call increase in the AP distance as opposed to your lateral distance, that we call typically a barrel chest, which is consistent with conditions like COPD. Okay, but also asthma can cause that, especially chronic asthma. Again, those are things that you have to inspect. Okay, are you seeing any obvious radiation tattoos? Are you seeing any obvious induration to indicate that the patient has been having some radiation for a certain malignancy? Again, those are all things that you want to pick up from the inspection. At the back, it's always useful to comment if you are seeing any obvious kyphoscoliosis. Again, those conditions are very common in things like Marfan. So you're thinking, are there any respiratory manifestation? Okay, remember, in your palpation, if you haven't done your neck exam on the general exam, you can check for tracheal deviation. Okay, however, we already did ours on the general neck exam, so it's okay, we move ahead. Then as you come from study, you can palpate. There are many techniques to palpate for costochondritis, but this is one of them. So you just go along the costochondral margins, you look at the patient. Is the patient feeling to be in any pain, which we cannot appreciate? So there is no obvious signs of costochondritis. Okay, then as you come down here, you want to check for chest rise. So remember, it's always useful to put your hand in this groove, okay, facing the xiphisternum. So you hold tight, and remember, your hands must be off the chest so that you see them move apart, because if you hold it like that, you struggle to move apart. And remember, the normal one is there has to be about a 5 centimeter distance in the movement as the patient inhales. Okay, so could you please breathe in? Again, like that. And always remember, whatever you do in the front, you also typically have to do it at the back. Okay, that's the palpation. Then the next thing that you palpate for is what you call tactile fremeters. Okay, again, there are multiple variations on what you can do it. You can do it bilaterally like this I'm showing, or some people prefer to do it like that. Some people prefer to use their palm. Okay, howsoever, you are just trying to elicit tactile fremeters, but always remember that it's very useful to do tactile fremeters, because typically one of those tests that you help you differentiate, for example, a consolidation from a pleural effusion. Okay, so what you want to say is, say, could you please say 99,
99,
99,
99,
99,
99, 99, 99, 99, 99, 99.
Okay, so we can appreciate that tactile parameters appear to be normal and symmetric on both sides. Okay, remember, if it's increased on one side as opposed to the other one, you're thinking it's a consolidation. If it's reduced, you're thinking it's a pleural effusion. Of course, there are other more differential. We are done with the palpation. Okay, then we are moving on to the percussion aspect of the respiratory system. Okay, remember, always try to ascertain your technique. It's always useful to put only one finger, sorry, and then you hit. Some people use two, some people take one. Remember, it's a swinging movement so that you make a loud noise for the examiner to hear you. Okay, typically we start supraclavicularly. Okay, and you. Okay, then remember, on the clavicle, you typically just want to use your hand. Okay, then you go. And remember, the chest is supposed to be resonant. If it's hyperresonant, you are thinking of emphysema. Is it bronchitis? Am I dealing with a pneumothorax? Okay. If it's dull, you are thinking, am I dealing with a pleural effusion? Okay, especially if it's stony dull, pleural effusion. However, dullness can be very subjective. So the gray zone of stony dull to just dull is always there, but by theoretic means, stony dull will be an effusion. If it's just dull, you are thinking of a consolidation. Okay, that's the level of thinking that you have to have. Okay, then always make sure that you percuss the whole anterior chest. Okay, remember, around the heart you will have some level of dullness, and especially from your fifth to your sixth intercostal space, that's where your liver typically starts. So you expect a level of dullness. Okay, so it will not be as resonant as the upper chest. However, if you do find that these areas that you typically should appreciate a level of dullness is now hyperresonant, and you are thinking is a patient overinflated, seen in conditions like emphysema. Okay, so that's very useful. And remember, whatever you percuss on the front, you have to make sure you percuss on the back. Okay, and finally, we're at the end aspect of the respiratory system exam. So it's your auscultation. Always remember that you use your bell side for your supraclavicular region. Otherwise, anywhere on the chest, we typically use the diaphragm. Okay, so say I'm just going to ask you to open your mouth and try to breathe in and out deeply as you can, like that. Okay, yes. Then you turn the knob. Okay, so remember, as I've listened to the patient, I had bilateral vesicular breath sounds. Okay, no added sound. Okay, so you want to pick up, is there any obvious wheezing? Is there stridor? Are you hearing transmitted sounds? What are you hearing? And always make sure, if you are not sure what bronchial breath sounds are, always put your stethoscope on the over the trachea. Okay, listen how it sounds. Those are the sound that you typically, if you are hearing anywhere in the chest, that's what we call bronchial breath sounds. Okay, and typically seen in things like consolidation, especially lobar pneumonia. Okay, so I could not hear any crackles.
Now he don't.
You can hear the squeaking near the end. Sometimes, however, it's not so easy to see or hear. In many kids, it just shows up as a cough at the end of a forceful exhalation, like here.
And that marks the end of the auscultation part of the respiratory system.